the metaphor is there. Everyone's used to it. It is the dog that caught the car. And that's a lot of what happens here, is that Republicans have been talking about it for years, and now they are in a position to actually do something. And what I would like to suggest for you is that maybe the sky isn't falling. Maybe, just maybe, you should, until you see evidence to the contrary, give deference to the possibility that Republicans actually don't want to do either stupid or suicidal things. That, in fact, they might want to cover people. So, if you will give me that deference for just a moment, you will set aside your disbelief. Debbie's going to be having to set it aside, and it's going to be really hard. But set aside your disbelief and consider the possibility that maybe, just maybe, they would like to actually do well. Maybe even, perish the thought, do better. But to get there, you have to start with this, which is you have to set aside the concept of repeal and replace. Repeal and replace is a slogan. The actuality of what we're looking at is better described as transition. Republicans want to have private health insurers provide coverage to individuals that is high quality, competitive, and is efficient to lower costs. I'm absolutely certain that 7 years ago, that's exactly what Democrats were thinking. And so the distance between where the ACA is, and I think where Republicans conceptually want to go, is an Uber ride. If we're talking about Medicare and Medicare reform, the distance between existing Medicare and premium support, you'd had best pack luggage, because that's a long trip. Okay? So if Republicans are here and Republicans are serious, there are three things that Republicans have to do moving forward if they want to actually show that they are trying to cover people. The first is they have to talk to insurers. And that is that if you want to build this system and you look at the current system as it is and see that there may be some flaws, I'm leaning away from Debbie as I say that
I agree.
There have been lack of successes, notice avoiding the use of the word failure. Some of the challenges is, I think, looking at what the decisions were made in 2009 and how the insurers have reacted since. And so for Republicans, they need to engage insurers. And if you're not going to listen to them, you better have a really good reason why not. And so that's the first challenge for Republicans. Second, disruption matters. You now own it. Republicans have been in this wonderful position for the last 7 years to be able to be as disruptive as possible with no ownership whatsoever. Now they own every bit of it. And so I can conceptualize the idea that you could have IRS take the individual mandate, create any number of carve-outs to make it functionally meaningless because you're against the individual mandate. And that's a policy decision. Just know that at the next open season, there will be no plans. They will walk. And so if you're ready to own that disruption, fine. But if you're concerned about disruption, you now have to care, which again, prior to Tuesday, they didn't have to. Third and final point, Republicans are going to have to make hard decisions. They're going to have to listen to people who heretofore, if you throw out a white paper, you have so much wiggle room to say it means what you say it means. And so I can look at a better way and go, I could see real ideas in here, but it's also like an ink blot test. I mean, is it an owl? Is it a VW Beetle? Is it a late enrollment penalty? It was a little harder to tell with that. But now they're going to have to actually make legislative decisions, write black ink on white paper to hand to CBO, to hand to Legislative Council, to hand to folks and say, make policy. And when you get to that point, you have to make hard decisions. And for me, one of the most evident decisions they'll have to make will involve, for example, Medicaid. For years, you can rail on the Medicaid expansion as done, but now if you're at the point to make a decision, if you want to cover people, reducing the match is not the way to go. And you will be told with great evidence, when 100% reimbursement still has 19 states not participating, if you go and reduce that, you're not increasing participation. You're just not. Now, you're going to have to get that information, be told that, and make the hard decision to actually change course or go full ahead knowing you potentially are making a very bad decision. It's possible. I'm not saying that it's actually going to happen, but I think you should begin any conversation deferring to the possible.
So we know for a fact we're making a difference. We know that we have cut the uninsured rate in the district in half since we started. We know that we are between first and third in the nation for covering the uninsured compared to any other state. That is due to the Affordable Care Act. It's also due to having a district government that is 100% committed to investing in providing coverage for its residents and to making sure that everybody here has affordable quality health care. That becomes much harder if the ACA is undone. And when I say undone, I mean in particular the Medicaid program. That would have the most devastating effect in the district. And I also mean the financial help that comes in the form of the premium tax credits and the cost sharing reductions. We in DC are seeing an uptick in enrollments this year compared to last year. We have a higher number of people in open enrollment right now applying for coverage. That is surprising because we have almost no one left uninsured. But to us, it speaks to the fact that this election is really has woken people up. A little too late, but it's woken them up. And so, I think what I would challenge to all of us here is what happens to the Affordable Care Act and to and more importantly, the coverage expansions that we've achieved is really up to all of us. I mean, we need to be the faces of people who have obtained coverage. We need to be my niece with brain cancer who was able to keep her health insurance. We need to be all the people who are doing their best and getting health insurance. And we've made the world a better place. And it is absolutely not time to turn the clock back. I believe there's a lot of hope here. I believe we can do it. But I believe we better get to work. And that's what I'm doing, and I hope it's what everyone here is doing, and now I'm going to be quiet.
I think in terms of process, when you talk to the transition folks, they do recognize that they got elected with a repeal-replace message. And their repeal-replace, they believe wholeheartedly that that's what their folks voted for. And when you talk to them, they say number 1 through number 10 is repeal and replace very early to send a strong message. They're looking at executive orders, executive actions, and a lot of this was done through sub-regulatory guidance. You're looking at over 1,000 executive actions on the Affordable Care Act that they're going through and figuring out what they can undo. I think you're looking at creative budget measures, whether you're looking at a two-step process early on where you get a budget reconciliation instruction for this past year that they would move on immediately to give the president the immediate ability to repeal and use that reconciliation bill from last December. The reason why that last December bill matters is it went through the so-called bird bath, it went through the parliamentarian, it was a lot of the legwork, it can move pretty quickly, it is a transition. I do point out that I think that the folks up there are now grappling with Rodney's point, which I think is a very, very important one. Who is going to be in open enrollment for 2018 if there's a transition? I don't know what kind of signal Republicans can give health plans to say it'll be okay to keep them in. I think part of that is that we have to demonstrate that we can get a coalition together. And frankly, part of that is whether the Democrats are willing to dance. If we repeal and presume that the assumption is an early repeal, will enough Democratic senators come up and say, we think that there's a path forward and we can maybe get the resolution? I think Debbie's right. I think a lot of that comes down to what President Trump does. I think we're in a really interesting 6 months. It's going to be extremely busy. And I think that if you're looking at costs, I think that is fundamentally what our side of the aisle seems to be focused on. Costs for small employers, costs for individuals in the market. And I think that's a lot of the messaging out of Republicans, a lot of the policy focus will be on that cost for those folks.
We're very proud of our patient-centered medical home program and the specialty care and cancer care aspects of that. We've seen 1.3 million people become members of that PCMH program. It's really the first and largest of its kind. We're coming up on our 6th year of operation and have avoided hundreds of millions of dollars in healthcare costs and been able to hold trend that way. So in many ways, while I am certainly mindful, concerned, scared of all the threats that Debbie raised and that others have said could happen. I don't know if that happens on January 22nd or 2 years from now or 3 years from now. depending on what effective dates are in the bills. But we're really focused on helping people get and maintain coverage that they have with us or that they will get from us, because people like Debbie are working very hard to help people understand that there's coverage out there that they haven't taken advantage of. I will add one asterisk to Debbie's comment, given the room that I'm in that it's not just important to get covered, it's important to get covered smartly. I've had the privilege of being with many specialty organizations and sort of just come right out of the chute by saying, if you're advocating for people who you know have high medical need, that $187 a month plan that looks like the cheapest out there, but has a $6,500 medical and drug deductible, might not be the best plan for them, when there's a $250 a month plan that has a $5,500 medical deductible, but a $150 drug deductible. After which they've met that $150 drug deductible, they've got free generic, 75 brand preferred, and then $150 brand non-preferred and specialty drugs. So that's what I hope, regardless of whatever happens next, we and those that we work with can remain focused on, is that the people that ultimately get and use whatever coverage is available to them in our service area, these are patients. These are people like my mom, and I want to make sure that they can get and access the coverage they have to get the care that they need. The one thing that we haven't discussed today is input costs, right? So our premiums don't follow the subsidies. Our premiums are based on the cost to cover that population, right? So we go to the state every year and we say, this is how much it costs to cover this population of people. And then Debbie and I will argue a little bit on whether it really cost as much or the morbidity factor was as high as we thought it was versus what they thought it was. And at the end of the day, they approve a rate, and then that's the rate that gets filed. In that cost, divided by the number of people, are all of the costs of the things that people use, the physician visit, the hospital stays, the prescription drugs. With the exception of primary care spending, which we want to see go up, the only other cost that's going up as a percentage in our health plan is prescription drugs. We are spending, if you look at both retail prescription drugs and drugs that are administered in a physician office, we're looking at 32% of every dollar that we spend on medical benefit going to prescription drugs. That's about 10 percentage points higher than hospital care. That's a great thing to me as a pharmacist if it means people are being treated at home with their family where they won't be harmed by drugs that are more effective and allowing them to stay home. But when I look at it from an actuarial perspective, what I'm seeing is the majority of that rising cost is due to inflation and not due to more people using more drugs that are achieving more quality. There's examples of both on either side. But I know that there are drugs that we are covering today that add a full percentage point to the cost of a premium. And it'll be very interesting to see, and these are tough societal conversations, it'll be very interesting to see what state legislators and the incoming administration starts to feel when the cost of covering drugs for some people is increasing the premium 5-6% for everybody. So as we start talking about how do we design plans, what is an essential health benefit? Can you ever sell a plan without access to prescription drugs? Can you ever sell a hospital-only, drug-only plan? Those are some of the things that are harder to talk about in a lighthearted conversation and really require a good look at some numbers.
Well said.
I will say this is the first time I've heard high-risk pool in the 2 panels I've been to in 2 days, which I find fascinating, actually.
You'll hear it more. You'll hear it more.
I figured it was coming back. I read a lot about it, but then when people are talking, it is good news. They're afraid to say it. People are trying not to say it. Rodney's not afraid to say anything. But you're asking precisely the right questions. Lifetime limits, annual limits, and if this moves to a high-risk pool environment for people who need health insurance, how is that funded? How is it real? We have tried high-risk pools for decades in this country, and they have not worked, and they have had waiting lines, and they have led to people dying because they could not get the health insurance they need. So you're asking the right questions. I want to put it back on everyone in this room. I mean, the faces of who benefits from these protections, these vital protections, need to be out there. One of the biggest failures of the Affordable Care Act are the proponents haven't spoken and haven't shown the case of the Affordable Care Act. I mean, I think that's really part of the reason we're in the reason it became so able to be vilified is because we did not tell the story, and we did not tell it as loudly and as proudly as we should have from day one. I take responsibility for that too, but we have to do it now, and we have to make sure that we have the protections, whatever they're called. I could care less what it's called. If you call it a high-risk pool and it's really a tax credit that makes everybody get health insurance, fine. If you call it the ACA and change, some provisions, that's fine too. But as long as people are covered and their health is protected.